Okay, we'll start week 2 with prenatal care. Couple abbreviations you'll have to know from your book are your GT-PAL system. G standing for gravida, number of pregnancies. P, if it comes before the T, meaning para, number of deliveries greater than 20 weeks. T, meaning term deliveries, so greater than 37 and 6 days deliveries. P, if it comes after the T, stands for preterm deliveries, so greater or less than 37 and 6 weeks. A stands for abortions. The thing to remember in OB land is abortions and miscarriages are the same thing, or considered the same thing. So you want to be careful with the terminology when speaking with the patients. It's still considered a miscarriage or an abortion if a patient loses a child or a pregnancy if it's less than 20 weeks. L stands for current living children. M would be multiples. So the GP would be gravida para. GT-PAL are gravida, term, preterm, abortions, and living. And then this is the same with the multiples added on. You will hear in OB primips, primigravida would be your first pregnancies or your first babies. Multigravida, multips, greater than, or this is not their first pregnancy, or they've already had a child. Nullagravida, never been pregnant. Physical assessment. So the difference in between your initial prenatal visit and your other visits. So your initial prenatal visit is going to be very lengthy. The patient's going to have a thorough interview. You're going to get their EDC. You're going to do a thorough assessment, weight, vital signs, a pelvic exam, including a pap smear. Have the patient empty their bladder before that. You're going to obtain labs at this first prenatal visit. Urine specimen, a thorough history, a lot of education on what to expect in the pregnancy. And a lot of times these initial prenatal visits are not done by the MD. A lot of times you'll see a nurse practitioner, midwife, or sometimes even a nurse educator. Your other prenatal visits after your initial visit are very short. They'll get your weight, vital signs, a urine specimen, check for edema. They'll check fetal heart rate, fundal height, make sure the fetus is moving, and then educate what's appropriate for that month. So after your initial prenatal visit, normally they do a monthly visit for 7 months, every 2 weeks during month 8, and then weekly during month 9, provided there's no complications. So what lab values do they get? And this is for your first prenatal visit, okay? This is assuming, okay, that your first prenatal visit is early, okay, assuming you find out you're pregnant, 6 to 10 weeks. Blood type, an RH factor, an indirect Coombs, hemoglobin, hematocrit, rubella, HIV, RPR, this is a test for syphilis, hepatitis B, okay. These are all blood tests, and then your pap smear, if moved down here, obviously is a pelvic exam. You must know what lab values are drawn on a routine prenatal lab draw. If a mom is Rh negative, okay, so their blood type is either A, B, or O, or AB. Their Rh factor is either positive or negative, okay? So if they're Rh negative, then they're going to receive RhoGAM during their pregnancy at around 28 weeks gestation. And we'll talk about why a little bit later. Also, if any invasive procedures are done, or if any traumatic event happens, if they miscarry, and then also within 72 hours after delivery, they'll receive another dose of RhoGAM if the baby is not the same Rh factor. Other lab testing to be done during the pregnancy, maternal serum for fetal alpha protein, and this is offered around 15 weeks gestation, and this is for genetic testing, okay? Glucose screening is done at around 28 weeks gestation, and this is from, this is a oral glucose that you drink, and then if your 1 hour is normal, you're fine. If it's abnormal, then you do a 3 hour. And then a group beta strep is done at 37 weeks, and we're actually going to have a guest speaker that's actually leaves a very lasting impression on you guys with group beta strep, so I'll leave that to her. But again, a lot of health promotion during these prenatal visits and education, not only at the first prenatal visit, but your ongoing visits. Also, signs of complications you want to educate the women on, not only at the first prenatal visit, but each prenatal visit that you see her at. Vaginal bleeding, persistent vomiting, chills and fever, any clear fluid from her vagina, abdominal or chest pain, pregnancy-induced hypertension signs, which we'll talk about a little bit later, or increased or decreased fetal movement. She'll want to report any of those to her provider. Chapter 12 goes into common discomforts in pregnancy and a little bit of self-care. Shows you the modified Sims position, and again, I can't stress enough, this is to prevent the supine hypotension syndrome. You don't want pregnant moms lying flat on their back. Things that are common in the first trimester: breast tenderness, constipation. We're going to tell them to drink lots of water, exercise, eat lots of fiber. Nausea and vomiting, they can eat crackers, drink fluids in between meals. Fatigue is common in the first and third trimesters. Muscle cramps, they can dorsiflex their foot to help get rid of those. And here's a picture of that. This is supposed to say to relieve leg cramps. Here's some more first trimester discomforts. Hypotension, and this is from lying flat on the back. Varicosities, you want to have them raise, elevate their feet frequently. Hemorrhoids, you want to prevent, so you want that high fiber, lots of fluid, water, prevent constipation. If you can't prevent it, encourage sitz baths, witch hazel pads, and topical ointments. Frequent urination is common in the first and third trimesters. So first trimester, you say, well, it's going to go away in the middle of pregnancy, but guess what? It's coming back. Abdominal discomfort is common. Round ligament pain is common during pregnancy. Backache is common during pregnancy. Pelvic tilt will help with that, and also a side-lying position. Here's a knee-chest position that can help with hemorrhoid pain. A pelvic tilt would be similar to this, except the back would be straight, and you would just kind of sag the back down and then straighten it out a little bit. And there's a short video at the end of this that we'll show. Here's elevation of your legs to help with varicosities. You want to encourage Kegel exercises, which is like if you go to the restroom and stop the flow of urine, in the middle of going to the bathroom, that's those pelvic muscles that you want to strengthen. This will help with urinary frequency. It will also help with the labor and delivery, the muscles that are needed for the actual labor and delivery process. It will also help with urinary control after delivery of the baby. Discomforts for middle to late pregnancy, again, backache, headache. As long as this is not a headache that's unrelieved by, just a regular over-the-counter Tylenol. We'll get into the signs and symptoms of blood pressure problems in a little bit. Shortness of air, common because that top of the uterus gets into the lung capacity way, and it's hard to take a big deep breath. Ankle edema, completely normal, as long as it's not pitting or upper body edema is not normal, but ankle edema is. Braxton Hicks contractions, normal. Preliminary signs. So how do we know labor may be around the corner? So preliminary means it could be a couple weeks away. Lightning. So the baby drops into the pelvis. Your belly drops. A slight loss of weight. Very little, not a huge amount. Excessive energy, they call this nesting. You want to clean everything. Backache, and this is kind of like a menstrual-like cramp. Ripening of the cervix, and this is the shortening and the softening of the cervix. So, your general lady out in public is not going to know this, but if you're actually checking a cervix, you may be able to feel this. Rupture of membranes, and this will actually send a woman to the hospital beginning of labor. Normal show, and this is from the cervical mucus, it's a mucousy discharge, bloody tinged. Bloody show is different from the loss of the mucus plug. Okay, loss of the mucus plug does not mean that labor has begun. It could mean that labor is a few weeks away. And then uterine contractions that get closer together and stronger despite the change in activity. Over a period of time. True contractions usually begin in the lower back and radiate to the lower abdomen. Some things that are harmful to the baby during pregnancy, some maternal infections. We usually refer to them as torch infections, which stands for toxoplasmosis. So you can get this from undercooked meat or changing kitty litter out of a litter box. So if you go to your GYN appointment and they ask if you have indoor cats, this is why. O stands for other, R for rubella, C for cytomegalovirus, and H for herpes. Vaccines. Some live vaccines could be harmful to the fetus. Obviously, drugs and alcohol. Some classifications of drugs. So a woman may take a prescription medication or an over-the-counter medication, and you can kind of leave it up to her on what the risk of that drug is during pregnancy related to the FDA risk categories of drugs. And here's a chart related to that. All right, just quick about nutrition. General weight gain 25 to 35 pounds, and this is for your normal weight lady before pregnancy. During the first trimester, about 1.5 pounds per month, and during the last 2 trimesters, about 1 pound per week. This is just a chart showing you that weight gain does not come just from the baby. Okay, different parts of the body gain different amounts of weight. Pregnant ladies need to increase more than just their calories. So they need, during the first trimester, to increase their caloric intake by about 340 calories per day. I'm sorry, that's during the second trimester. During the third trimester, around 450 calories per day. Increase their protein. Increase their iron and calcium. And increase their folic acid intake. Folic acid increases, or not enough folic acid increases the risk for neural tube defects such as spina bifida. The problem lies in most of your neural tube stuff is developed before women even know that they're pregnant. So you'll see a big push for folic acid intake of people that are of childbearing age before they even know that they're pregnant because of that. But during pregnancy, it's recommended that women take 600 micrograms per day. Foods to avoid. Caffeine. You want to limit. If you can avoid it, great. But if not, you want to limit it to 300 milligrams per day, which equals about 3 cups. Artificial sweeteners. Mercury, which is found in fish, and obviously one that's missing here is alcohol. Common problems. This pica cravings is craving abnormal substances such as chalk or laundry detergents, and this usually comes from an underlying deficiency. And you want to treat the underlying deficiency so these abnormal cravings will go away. To relieve heartburn, it's a myth that the baby will have a lot of hair if you have a lot of heartburn. So to relieve heartburn, you want to elevate the head for 30 minutes after meals, decrease greasy foods, and make sure the patient checks with their healthcare provider before taking any over-the-counter antacids. Also, common problems you might want to address are finances and to see if moms need any WIC referrals, which are Women, Infant, and Children is what WIC stands for, W-I-C. This is just a chart for prenatal vitamins, which we give women prescriptions for or they buy over the counter. It's important to know for vegetarians or vegans that they may be low on protein, calcium, iron, zinc, and it's important that they take a vitamin B12 supplement. There are several different methods for childbirth education. This is moving on to chapter 14. The Bradley method stresses partner involvement and trusting your body. Lamaze focuses on preparation and involvement of the birth process. There's also a Dick Reed method and a LeBoyer. LeBoyer method is birth without violence. They focus on like water bursts and dimming lights. Dick Reed is childbirth without fear. They kind of mingle together a little bit. This just kind of goes over some, comfortable exercises or positionings that pregnant women can do to prepare for labor. I want to mention that maybe in clinicals or in your own experience when you see a woman in labor or you watch a video and they go to push, you'll see them hold their breath in the lithotomy position and the nurse will count to 10 and they'll take a big deep breath in and then they'll hold it and count to 10 again. Actually, the evidence-based research shows that that's not what's recommended. Actually, what's recommended is open glottis pushing, and where the woman contracts her abdominal muscles when she's actually still breathing in and out, which is easy to do. Like right now, I have my abdominal muscles contracted, but I'm still breathing in and out, and you can still bear down. Harder to do with an epidural, but some women, if they make noise or if they grunt, it's easier for them to do. So open glottis pushing is actually recommended. A few pictures, tailored setting. This will help stretch the muscles and open the pelvic area, same with squatting. Here's a picture of the pelvic rocking that we talked about a little bit earlier to help with back pain. And what's good with this is the partner can actually get behind mom and apply some pressure to the lower back if mom's having back labor or back pain, and really help with that. Effleurage is a comfort technique. It can be used anytime. It's just a light massage with the fingertips, okay, over the abdomen or over the thighs. It's basically a distraction technique for mom. And it's a question for you. I'll let you kind of look this up of what a doula is versus what a midwife is. And we'll talk about this a little bit in class.
That is cool. So Kristen is sitting on the birth ball. You do this. You can do this during pregnancy. Do this in early labor, even late labor if you feel like it. Open up your pelvis.
Can you bounce on it?
Yes. Rotate your hips.
There you go.
Can help bring the baby down into the pelvis.
Perfect.
Do a deep squat.
Okay. And what does this help?
This also helps open the pelvis. I think by like 10%.
Is it hard to do when you're pregnant?
Yes, you can do both. If you have a hard time. If you do have a hard time, you can in front of your chair or your partner.
Okay. All right.
Lower back. In pregnancy more than in labor. Just to do this when you're folding clothes or watching TV or whatever. And it helps to open your pelvis then.
Okay.
You can do these. You can do this also in pregnancy or in labor. And you can do pelvic rocking, which you start with your back flat, and then you let it sway in, and then just go to flat. Don't over extend, just flat, and then drop. Helps take pressure off your spine. Yeah.
So it helps your back.
Yes.
This is when you can apply that counter pressure there too, or the support person could.
Lunging, and you can use some for support. Either way. Probably more for pregnancy rather than in labor, but either way, I guess it's comfortable to you. What else?
Sideline's pretty simple. Anything in the bed that they could do, like
Yeah. Put that all the way up. Lean over. And you can have whoever your support system is, they could be doing hip squeezes or counter pressure on your back, whoever labor. So that's a good one. And you can do squatting and anything else. It's cool that you can do any of the squatting. I wouldn't do it, without someone supporting you, but if you're just needing some extra something to lean on. Also use this flat part. Right.
I don't think we have one here.
or just if you're in labor and in bed or in the hospital, you just want to be totally like relaxed. So you can have several pillows and just be totally, you know, relaxed.
I don't know if that's going to do it, but close enough.
Several pillows. So just so your whole body, so you're not tensing up anything. I think is the main thing. So your arm's not just hanging. So you. And you don't have toddler in the room either.
So we would ask him to step out.
Yeah, that's why you're probably needs to step out.
All right, so she does a pretty good job. We kind of had a toddler there letting us know what he thought about the situation. But she did a pretty good job talking about different positions that were good for pregnancy and labor. And we'll talk a little bit more about labor positions for different stages next week. So moving on, so complications of pregnancy. So we went through quickly the prenatal visits and a little bit of the norms of pregnancy. So now we're moving on to the complications. I believe these might be in just a little bit of a different order than what's uploaded, but they're the same slides because I changed the order to match the order that's in your ATI book. So don't freak out when your slides are just in slightly a different order, starting, I believe, with this one. So cardiac disease, these patients, there's different classifications based upon the severity of your pregnant patient's cardiac disease, 1, 2, 3, and 4. They are evaluated at months 3 and 7 during pregnancy. This is all in your ATI book. You want to know the level of exercise, if they have any cough or edema, baseline vitals, their liver size, get a baseline ECG on them. Obviously, you're going to do frequent fetal assessments, promote rest, promote healthy nutrition, educate regarding any medications they may be on, and regarding prevention of infection. So if they're having any procedures done, and say they have mitral valve prolapse, you're going to put them on a prophylactic antibiotic for that, to prevent endocarditis. Patients with pregnancy have an increased cardiac output anyway, so with cardiac disease, that puts them at increased risk. They want to avoid high vitamin K foods. They may be on digoxin or heparin. With labor and birth, these are your patients that are going to have epidurals, because you're going to want to, you're not going to want to increase that workload of their heart by putting them in pain and increasing their heart rate. Also, your normal lady, when she delivers that placenta and that loss of blood, that increased blood volume and that huge loss of blood, normally, a healthy woman can compensate for that physiological change, but a lady with some cardiac disease may have a harder time, so you want to watch her more closely. A lot of these women are not going to push, okay? So we either are going to see assisted deliveries with vacuum or forceps, or even cesarean sections. Frequent monitoring of vital signs, and postpartum you're going to assess for heart failure and also frequent assessment of the baby. I'm going to skip over some of these. Just for time purposes, I'm trying to keep these pre-lectures rather short, which I'm having a hard time doing. Diabetes in pregnancy. We don't test for gestational diabetes until around 26 to 28 weeks. So there's a glucose challenge done at that time. a 1 hour glucose, and then a 3 hour if that's failed. If there's gestational diabetes, there's an increased risk for hydramnios, ketoacidosis, hyperglycemia in both mom and the baby. After delivery, you will see hypoglycemia in the baby. So mom's blood sugar's been really, really high, so the fetus starts making more insulin. When the baby's born, it continues to make that insulin, but it no longer has the high blood sugars from mom, so its blood sugar will drop. Babies will tend to be macrosomic, which are large babies, so they're at increased risk for shoulder dystocia. These moms are going to do daily blood glucose monitoring, hopefully diet controlled with diet and exercise. If not, we're going to put them on insulin, not oral medication, but regular insulin. Some moms require insulin pump therapy. These are just your glucose monitoring guidelines. This goes into your bleeding. So what do you see with your first trimester bleedings? These are your miscarriages or your ectopic pregnancies. So if a mom comes in her first trimester, which is 0 to about 12 to 13 weeks pregnant, then she's either miscarrying or you suspect an ectopic pregnancy. You worry about isoimmunization, so if she's Rh negative and she's miscarrying or has an ectopic pregnancy, you're going to give the RhoGAM. You also worry about hemorrhage or infection. If it's an ectopic pregnancy, you worry about that rupturing. Mom will feel a unilateral stabbing, pain, and tenderness in the lower abdomen. Referred shoulder pain if it ruptures, and you need to get her to surgery immediately. And she may lose that tube if that ruptures. Second trimester bleeding can come from premature cervical dilation, or what we call a hydatiform mole or a molar pregnancy, which is an abnormal proliferation, degeneration of a thrombophoblastic villi. It's a grape-like fluid, grape-like clusters that swells from the placenta. There's two different types, complete and a partial. The complete is paternal only. There's no fetus, no placenta, no amniotic membranes or fluid. There's no placenta to receive maternal blood. And about 20% of these turn into a cancer. The partial comes from maternal and paternal, contains abnormal embryonic or fetal parts, an amniotic sac, and fetal blood. But there's congenital anomalies, and about 6% of these turn into cancer. So with these molar pregnancies, you really want to stress the importance of follow-up. These molar pregnancies have a really high HCG level. They also, mom's abdomen will grow much larger than what it should be for the amount of weeks mom is pregnant. She will have a prune-colored discharge. And I believe on your slides I have a picture of what the grape-like clusters may look like. Premature cervical dilation. The cervix will not stay closed until term, and they do a cervical cerclage. They just sew that shut until it's time to deliver, and then they go in and they just cut that string, in which time it usually delivery is not long after that. Third trimester bleeding. So we have placenta previa, which is when the placenta implants lower in the uterus So it usually implants at the top. Placenta previa, it implants lower. So here's your uterus. Normally the placenta implants somewhere up here. Placenta previa, it implants somewhere down here, depending on if it's partial or complete. You will have painless vaginal bleeding. And here's pictures. A lot of times they'll do bed rest. Sometimes it resolves on its own. Absolutely no cervical exams. If you know this or suspect this, because if you go in there with your fingers, you may cause a hemorrhage. You may tear that placenta away. If these moms may get, if early delivery suspected, maybe a shot of VID00010, 2 shots of VID00010 to help develop the baby's lungs. Abruptions. So the placenta prematurely separates from the uterine wall, occurs suddenly. It's the most frequent cause of perinatal death. So trauma, drug use, things like that are risk factors. Mom will come in, usually if it's a complete abruption, intense pain, board-like abdomen, okay? She could have bleeding, but not always. Not always visible from the vagina. The board-like abdomen is from the internal bleeding. It may not be actually coming out. Of course, vital signs, fetal assessment, and if it's a complete abruption, we're going to do an emergency delivery. Here's pictures. I don't have a slide, but a vasa previa is where the fetal blood vessels are crossing over the amniotic membranes over the cervical os. So when the membranes rupture or when they're artificially ruptured, you actually rupture the fetal blood vessels and the fetus bleeds out. So that's also can be an emergency situation. Preterm labor, labor occurring before 37 weeks and 6 days. Know the risk factors for preterm labor. What can be done? Bed rest, pelvic rest, meaning no sex, nothing in the vagina, hydrate mom, treat for any suspected infections. We could do a fetal fibronectin test. So it's if it comes back positive, it could tell us that mom's at increased risk for preterm delivery. Measure cervical length by ultrasound. If it's shortened, that means she's at increased risk. We could do a biophysical profile, non-stress test. That's testing the baby's status. We could give antibiotics. That's for GBS. Tocolytics, so if mom's contracting, this is your terbutaline or your breathine, which this will cause tachycardia. So you want to tell mom to make sure she checks her heart rate before, because if she's tachycardic before she takes it, she's not going to want to take it because this will make her heart, way higher than it should be. Also, you want to caution her, or you want to watch for pulmonary edema with anybody that's taken terbutaline. VID00010, steroid for the baby's lungs. If you think it's going to be born early, you want to make sure that lung development is good. Has to be on board for at least 24 hours before it's effective. Also, magnesium sulfate can be given to stop preterm labor. It's a muscle relaxer. It stops those contractions. We are not going to stop labor if mom's greater than 6 centimeters dilated. Okay, that's kind of like the point of no return. Preterm rupture of membranes before 37 weeks. This is associated with chorio, meaning infection of the amniotic fluid, because the amniotic fluid serves as a protective barrier around that baby. Pregnancy-induced hypertension. Very, very important that you understand pregnancy-induced hypertension and the definitions. Assessment of pregnancy-induced hypertension. There's a nice video that you have access to for week 2 from SimLab that I'll let you go over, because I will expect you to know how to walk in and what assessments to perform on a patient that you suspect may have pregnancy-induced hypertension. So what are we going to do? Obviously protect the patient. One thing you won't see in the video, because it's with Sim Mom, it's a mannequin, if you suspect that the mom may have a seizure or is close to seizure activity, obviously put her on seizure precautions. The medication of choice is magnesium sulfate, so I want you to look it up and be very familiar with magnesium sulfate, which I had just mentioned for the preterm labor. So it's given for preterm labor, and it's given for pregnancy-induced hypertension. So in the video that you watch, you're going to hear me mention lab values. Okay, HELP syndrome is kind of like a form of pregnancy-induced hypertension. Okay, once they reach HELP syndrome, okay, they're getting delivered. So HELP stands for hemolysis, elevated liver enzymes, low platelets. So your liver enzymes that would be elevated are your ALT and your AST, and then your low platelets. So when I'm asking you for lab values, I want to know ALT, AST, platelets. I want to know, is there protein in her urine? What about her BUN and her creatinine? Okay. Her hemoglobin. Her urinary output. It's not a lab value, but that's another thing that I'm going to want to know. And just, again, make sure you watch that assessment piece video that I have uploaded for you.